Good afternoon, everybody. My name's Leanne Wells, Chief Executive Officer of the Consumers Health Forum of Australia. Welcome to our regular budget webinar for members and reps. Jo Root, our Policy Director, and I are going to be taking you through our take on the budget. We'll start with some overall remarks, a bit of an overview for you on what some of the other key national stakeholders are saying. We won't be going through the detail measure by measure, obviously, but just going through some of the headline measures that we felt were particularly relevant to consumers. We'll be taking questions in the Q&A box, so that is active, but we have disabled the chat function. If we don't get to all of your questions through the course of the webinar, we will certainly send out and circulate answers to those registered for this webinar early next week for you. We have received some questions from members in advance of this. We will also respond to those directly as well. So before I start the presentation, I'd like to acknowledge the traditional custodians on whose land I'm meeting today, the Ngunnawal people here in the ACT, and acknowledge that we have members tuning in from right across the country, but to pass on my respects to the Ngunnawal people, their elders past, present and emerging. So I think it was fair to say that this budget, we were all anticipating that it was going to be a budget like no other. It was Budget Eve was certainly in the context of COVID. The 2020 has been the year of COVID that really has shown us, and we've seen that come through in the budget too, and how it's constructed. I think how inextricable the link is between the health of the community and the vitality and productivity of the economy. I think also just contextually with this budget, we also saw newfound community trust in government and strong support for government spending on public health services. So strong and positive community sentiment around the value of our universal Medicare, PBS and public hospital systems. And that's reflected in the government response. A record investment in health over 4 years of some 467 billion, up a considerable 332 billion over last year. So in terms of the way the budget's constructed, I think it's fair to say there were quite a few re-announcements of measures and packages that we had previously known about, and robust provision for 16.5 billion for the ongoing COVID emergency response. But apart from that, we believe that the remainder of the expenditure really represents some down payments rather than significant investment in primary care, aged care and mental health reform. So we're not seeing complete packages reform in those areas, partly because and largely because I think there are big processes underway like the Royal Commission, the Productivity Commission as far as mental health is concerned, and a ministerial task force looking at primary care 10-year plans. So the welcome measures, and there were many, included telehealth and a continuation of the telehealth arrangements for GPs, allied health and specialists to March 2021. So that's a 6-month extension there. Aged care home packages, some new aged care home packages, expanded mental health services, primarily in the form of the additional 10 visits to psychologists and other eligible allied health providers under the Better Access program. Investment in vaccine manufacture, supply and distribution, very important for us all. Some really good measures in rural health, and a mixed bag of things in relation to private health insurance coverage, but particularly in relation to extending private health insurance coverage to hospital in the home services that would have otherwise been provided in hospital, which we've welcomed. There are other elements of the private health insurance package we have been less effusive about, and Jo will talk about those later. The big areas of deficit, I suppose, included preventative health. I think many of us are looking for still a substantive investment in preventative health and in evidence-based measures there. Future pandemic preparedness, apart from the vaccine provision, there's nothing in the budget that would give us confidence that that's being provisioned for. And as I said before, systemic investments in those really three big areas of reform there on your slide. Okay, so stakeholder views. I think it's very interesting for us and you as our members to get a sense and a flavour of what others are all saying. All national stakeholders appear to be saying and agreeing that additional funding to meet the COVID pandemic was necessary and welcome. Increased spending on medicines, particularly with increased spending on new life-saving and prolonged treatment, was welcome by consumers and industry players. As I said before, some, and that includes the AMA, the College of Nursing, several others, including ourselves, identifying the lack of a long-term reform agenda in this budget and therefore seeing it as a budget opportunity missed. But I think that then brings us to the 2020 budget. There is going to be great expectation and extra pressure on the 2021 budget, which is really only 7-8 months away, and therefore the government's going to have to have some pretty good ideas about what's going to go in that in the next 6 months around the response to the key reviews that are underway. Prevention I've talked about. And then, again, the relationship, the factors that do bear on health, job seeker, rent assistance, all of those factors that really expose the flaws in our system on one hand, but the importance of thinking about the social determinants of health, the failure to move permanently to increase job seeker rates, and lack of action on rent assistance were problems identified by a broad set of stakeholders, obviously including and led by ACOS. COTA and others reinforce the view that the aged care measures must be seen as a down payment on longer term reform. I think that goes without saying. Huge expectation there, serious failings in the system, absolutely compelling a big response from government now and into the future. We think, and I think others agree, that the timeline for COVID vaccine underpinning the budget is probably ambitious. Lots of opinion one way or the other on that. And then lastly, as Research Australia points out, the additional money for research, absolutely welcome, but really goes nowhere to making up for the full impact of COVID-19 on the university and research sectors. So that's a very broad brush overview of our takeout and what others are saying. I'll hand over to Jo now to take you through some of the more specific measures in the budget. Thank you.
Thanks, Leanne, and welcome to everybody. We're just playing musical chairs. The COVID-19 measures were necessary, and I guess a lot of this documentation in the budget shows that they were actually accounting for money that had already been spent and money into the future. The range of COVID measures covering health and aged care continues, and there's obviously have to be more spent. The aged care response plan probably doesn't go covered off the issues. The inclusion of additional grief and bereavement we've highlighted here because we think this is often overlooked, and with the deaths in Victoria, in particular in aged care, this is an area where we need to do better. The funding for increasing the national medical stockpile is essential, and this needs to be maintained because one of the things that was highlighted is that actually our stockpile had diminished. And it also draws attention to the fact that there is nothing in the budget saying that there will be future proofing for other pandemics. The view at the moment is that we probably need to start preparing now for the next pandemic, which for those in Victoria, I'm sure fills you with horror, but I think it is important that we get planning. So there's the COVID measures that we've highlighted, many of them temporary, and we're hoping to move some of them to permanent. In income support, Leanne's already touched on this. There was no permanent increase to the job seeker rate. It's at its current rate until the end of the year, and it's not clear what's going to happen there. That's left a lot of people with a very uncertain future. There was some temporary relief for some through the $250 support payments, particularly for age pensioners and people on seniors' health cards and some other groups. And the JobMaker hiring credit to support people into employment has come under some criticism since the budget because of it being aimed at people under the age of 35. And some of our members, including COTA, have come out and been quite concerned about the impact this will have on other people's employment rates. So that's probably the biggest deficit in the budget. Primary care, extension of MBS funding for telehealth to March 2021. So again, we don't have a permanent commitment to MBS funding for telehealth, although the Minister in his webinar on budget night did say that seemed to indicate that the intention was to have a permanent measure, but what it actually looks like, we don't know. So at the moment, it's still temporary, and there's some work being done on getting a permanent process in place for that, for both GPs and for specialists. There's no expansion of funding for the voluntary patient enrolment plan, which was announced last year, despite the fact that the measure is going to probably move from, instead of just being for 70-year-olds, to a population-wide model. So that's kind of maybe will come out when we get the 10-year primary healthcare plan in the next budget. CHF is on the steering committee for the primary healthcare plan. Leanne's on that committee, and so we are seeing what the government is thinking about longer term, but well, hopefully it will be in the budget in 2021. And there's the measures and the dollars there, and we'll see as they roll out. And we're particularly pleased to see the expansion of Aboriginal and Torres Strait Islander health primary healthcare services. Improving access to medicines, the government has given a commitment ever since it's been in government that it will fund PBAC recommendations for new medicines. So, so this is important that we fund new medicines as they come available. We're very fortunate in Australia. The PBS is one of the strong planks of our universal health system. Other countries don't have access to new medicines in the same way we do, and this is a commitment that was made when this government came into power, and they've honoured that commitment. They're entering into new agreements with Medicines Australia and the Generic and Biosimilar Medicines Associations. These help to make sure that medicines become available to Australians. And the government has negotiated and funded a new 7th Community Pharmacy Agreement, which was negotiated and signed prior to the budget, but obviously the funding has to come out through the budget process. 18.3 billion for pharmacy dispensing and medication management programs. And CHF has been included as a member of the Stakeholder Advisory Committee for the 7th Community Pharmacy. This is the first time we've been involved in the governance of the Community Pharmacy Agreement, and we're hoping that we'll get an opportunity to influence some of the rollout of some of the measures in that agreement. And as you can see from there, part of the pharmacy agreement is about the fast track, part of the pharmacy spending is fast tracking of electronic prescribing and continuing the home delivery of medicines to protect people, which started during COVID and has now become a longer term measure. Very important part of getting people their medicines as they need them, when they need them. This is the area where there has been the most criticism of the health budget, and that's prevention. There's nothing specific for prevention and preventative health, and that is a deficit in the thinking. We are hoping that it comes into the budget in 2021, as the National Preventive Health Strategy is due to be released then. It also, and I think that's where people like the Public Health Association of Australia have been quite vocal on that issue, and the lack of investment in social determinants, which we've already discussed, where there's no increase in income support payments and social housing did not get any funding, we think is a problem. But this was what was included in prevention, and it was all good ideas, all good issues, not probably what most of us think of as prevention, or but mainly looking at very specific issues and not national agenda issues. Aged care and older people's health, increased investment in aged care. I think the Royal Commission has now put out 2 reports. It's put out its interim report some months ago, and just before the budget put out its special report on the impact of COVID in residential aged care. The government has committed to putting in place the measures that were in the COVID report, and has made a commitment to report on those by the end of the year. So that will be good. That'll be around infection control and making sure that there is some adequate provision for the coordination of aged care and health services to make sure people get the care they need, particularly when they get COVID. There was an increase in home care packages, but it was only a quarter of what's needed, really. It was 23,000 additional places. The waiting list is over 100,000 people. So it's still a long way to do to catch up the shortfall. And of course, as we have the aging of the population, the demand for home care packages is increasing all the time. And some people feel they're being forced into residential aged care because they can't get access to a home care package. And that's not where anybody really wants to go. The measure to reduce younger people in aged care is a good beginning, but one of the issues is the measure helps people find alternatives to residential aged care if they need that kind of supported accommodation. What it doesn't do is increase the supply of those alternatives. So it's really that matching people up with something only works if the something is there for them to go to. And that is the next stage here. And there was some support for dementia care and support, again, building on what's been made available in the past. The big issue with aged care is probably that when the final report from the Royal Commission comes down early next year, the government will need to do a full response, and I think that will hopefully be in the budget next year, if not before. Rural health, there was announced a stronger rural health strategy worth $500 million to expand training opportunities for doctors and encourage more multidisciplinary care. The expansion of the Rural Health Multidisciplinary Training Program will continue to provide benefits to rural communities. And an interesting trial of new models for primary health care in smaller rural communities in 2 areas of New South Wales initially for the trials, in Western New South Wales and Southern New South Wales, will look at ways to better utilise and integrate resources. So rather than having a one-size-fits-all, it will try to use what is already available in a rural community, use what you've got better, make it better connected, make it suit the needs of the local community, and then hopefully we'll see if the trials show that this works, then the aim is to look at how this can be rolled out further, but it's a trial limited in those two areas. Private health insurance, always of interest to consumers and to Consumer Health Forum, an ongoing issue, I think, for many of us. I guess the headline for us is, yet again, it's piecemeal policy initiatives. We've been consistently calling now for at least 6 years for a Productivity Commission inquiry into private health insurance. It needs to be looked at thoroughly. What we've got instead is bits and pieces. We've had several tranches of reforms into private health insurance now, and each one just picks off a piece and doesn't look at the whole thing and doesn't look at the whole value to consumers and value to the community as a whole, not just those with private health insurance. So again, no full inquiry. We welcome the provision of home and community-based mental health and rehabilitation. Many consumers like it. It's been trialled by some providers up in the past. It's been well received by consumers. It does give people more choice. I think the key issue about that is it needs to be done as a choice discussion between the consumer and the clinician, with the private health insurers staying out of the equation and just making it possible, but it needs to be a discussion between a consumer and their doctor, and take into account the desires of the consumers, their home circumstance, whether it's possible, and look at what is the best option clinically and for the person in their where they're up to in their life and their disease. The budget announced 2 actuarial studies of private health insurance, the lifetime health cover and the risk equalisation model. We've been calling for a review of the lifetime health cover, which cuts in at the age of 30. And we've been saying that it acts as a disincentive for some people to take up private health insurance. If you miss out on if you don't take it out by the time you turn 31, then the penalty rate of 2% a year very quickly makes the product unacceptable and unaffordable for people. So we're very happy to see that looked at. We're very happy to see the risk equalisation model looked at. The actuarial study should be the start of this process. We believe that this needs to be a public process with transparency of the outcomes of those actuarial studies, so that and call for public input into what happens next, not just a closed process where it just goes to government. We need to see a transparent review process, which goes back to our call for a Productivity Commission inquiry. The expansion of the Medical Cost Finder website is welcome, and they're going to spend quite a lot of money on this. They're hoping to move it from having just general information about fees to actually putting individual specialist fees up. And that would be the really important next step of that website. I think as a consumer, people want to be able to go onto the website and look up Dr. X and see what Dr. X charges for whatever it is, for the hip replacement or whatever the service is. They don't want to just see that it could be between, $200 and $400 for an appointment. They want to actually know what they're going to be paying, if that's going to help them choose their specialist. And we believe that there also needs to be a consumer awareness campaign about that Medical Cost Finder website and encouraging people to use it. The increase the age of family dependence from 24 to 31 has the potential to increase benefits. This benefits paid, and so could increase premiums. We've welcomed the move in a sense that it gives some people the choice. It's particularly important for people with a disability who can then stay on their parents' private health insurance. The aim of the exercise here is to encourage people to keep being a private patient up until the age of 31, when they can then take out their own cover. So to move seamlessly from being on your parents' cover to being on your own. The government has said this should be done without increasing premiums, but that's our big concern about it. As you can see, two of the main measures actually don't cost the government anything. They require the private health insurers to do things differently. And the government is acting as a facilitator by changing the legislation to allow them both. Mental health, more Medicare funded better access psychology sessions as recommended by the Productivity Commission, which is good. The rest of the Productivity Commission recommendations haven't been addressed in this budget. On the better access psychology sessions, one of the big concerns is that there isn't the workforce to meet the demand for more services. Psychologists already have waiting times, particularly in rural areas. It's a big issue. The other concern that we really have is the out-of-pocket costs involved with psychology sessions under the Better Access program. Most psychology sessions are not bulk billed, so there's an out-of-pocket cost. So people can't afford more sessions if they're going to be going to have significant out-of-cost. If it's $100 out-of-pocket cost, then many people won't be able to afford more services. So more needs to be done to increase the supply of psychologist services. Work needs to be done on how to provide them without the high out-of-pocket costs that people incur. And there's the measures in detail, and we're still waiting for the government to table the Productivity Commission report on mental health, which they've had for several months now. On Indigenous health, there's funding for Indigenous health. There's a new Close the Gap agreement, which was signed off earlier this year, which gives the community controlled sector much more say, and Aboriginal people generally, more say in what the goals are, what the targets are, and how these should be achieved, all of which was very welcomed, and it was a jointly negotiated position. We think that's good. We think more money for the community controlled health organisations is very important. They are the cornerstone of much of the good work that is done in primary healthcare for Aboriginal and Torres Strait Islander people, and they provide a model which is culturally appropriate for many people. And the last area that we covered off on was research, and the $1 billion through the research support program is basically core funding for universities, is very welcome. But as many have pointed out, Research Australia, AMRI and others, this really comes at a time when the university sector is being quite hard hit through COVID, through funding, are laying off staffers, are laying off staff. Researchers, particularly early career researchers, are struggling to get funding and keep their positions. So it's probably not sufficient. But we think that more needs to be done on research, particularly as we've seen the value of research through COVID vaccines and development of initiatives such as the vaccine rollout and mental health research, we think are areas that need more work. And there's some of the research measures in detail. If you want more information, then you go to the budget website on the Department of Health. There is a link in the slide set, which is on our website. Treasury, you can have a look at the budget papers in detail. And there was today's webinar, and the slide set is on our website from this webinar. So we'll go to questions, Anthony. Have we got any questions coming up? Okay, Mark Diamond, thanks for the question on telehealth, and Eileen, everybody's interested in, and we had another couple of questions on telehealth. I think the issue with telehealth is that actually it got rushed in as a response to an emergency. We'd been talking about it for a long time. We're having to sort of modify it as we go. You know, it started off as bulk billed, and then it wasn't bulk billed. It started off being available to everybody, and we've gradually moved it so that you have to have an ongoing relationship with your general practitioner. We think, I mean, that's why the government hasn't made it a permanent move yet. CHF's concerns about telehealth, I think it's fair to say, are whether it's video or just a telephone. The payment is the same at the moment. The vast bulk of primary healthcare, GP services under it have been by telephone only, not by video. Specialists have done fewer consultations, but where they have done them, more of them have done them by video. We're not sure which is better for people. Often the view is that it is video, but actually the research is not conclusive on that one, and it just depends on what the process is. So there's some discussion about whether there should be a differential payment for video and telephone, whether people should be able to get them because you want it, because your doctor wants it, who should make the decision about whether a telehealth consultation is appropriate. I know there has been some reports of people saying they want a telehealth consultation and the doctor hasn't been prepared to give it. Now, there may be very good clinical reasons why the doctor doesn't think a telehealth appointment is a good one and they want someone to come in. It may just be that they don't offer it. And so I think there's an issue there. We don't actually know what the quality of these services is. We don't know how people we don't really know what consumers think of telehealth either. One of the pieces of research that we'd like to see done is to get a view of what people want. What has been people's experience of telehealth? Does it work for you? What do people think are the barriers? And we're pushing to get some research done on that. And the other issue, of course, is that for many people, telehealth isn't an option by anything other than telephone, and even that might be problematic because they simply don't have access. They don't have access to internet. They don't have reliable access and good enough access to do a video consultation. So a phone consultation may be the only way. And until we can fix the infrastructure and get a better NBN and get one that provides the same level of service to everybody, we're always going to have that digital divide. So we need to make sure that telehealth isn't seen as the answer to everything. Rebecca has asked about, made a comment really about the missing prevention response. It will be interesting to see what comes up in the prevention strategy. Again, CHF is on the steering committee for that prevention strategy, which was due this year, and because of COVID, reasonably enough, has been deferred. It's going to come out at the same time as the primary health strategy. And so we should have both of those as the key reform agendas for this government in health in the early next year. Somebody's asked to clarify what happens to people using telehealth between March and the budget June next year. We would hope that the government will put in place measures that will take us from March forward before the budget. So I think the minister is very aware that most people want to keep telehealth. I think the plan is to keep it. It's just when the announcement will be of what is in place. It may be that the current arrangements get rolled over again until a new model, a new permanent model is put in place. But I think there's very little doubt, and Leanne can tell me or not, that it will continue. It's just what it will look like, we're not quite sure. Somebody else Annie has asked about long COVID-19 patients will be being supported through new Medicare items. I think that's a really interesting question. Somebody else asked us that as well. I think the long COVID work, the National COVID-19 Clinical Guidelines Task Force is just starting to have a look at the evidence around long COVID. I think it's becoming clearer that there is a tail that people have, that COVID can give you a long COVID or a chronic disease. One would hope that those would, if that becomes the case, that we are clear that that is what is happening, then the argument would go that people who would get funded under the chronic care plans. But I think there's a long way to go on showing what the long-term effects of long COVID is, because nobody's had it long enough to know how long is and what the implications are. I think so the research community and the clinical community are still having differing views on the long COVID. Suzanne is picking up on telehealth again. We're obviously not going to get away from telehealth today. It's the key issue for everybody. Telehealth is Suzanne's saying telehealth is a complement, not a substitute service. It can be a substitute for some face-to-face consultations for some people. It can be in addition. It can be complementary to what services you might have, but for some people it is a substitute. And if we take the broader agenda of virtual care, then we do see with outpatients and with hospitals that have moved to providing services to virtual care, that they probably won't ever go back to some of the practices that they had before. And so telehealth would be giving some people more options, and they might, where you used to see your GP face-to-face 4 times a year, you might see them once or twice face-to-face and have the other 2 as a telehealth consultation, which would mean it actually is a substitute, but it should be seen as a package. And that's the thinking of the government in saying you need to have a long-term relationship. You need to have at least 1 face-to-face every 12 months, I think it is. And so we're not seeing it as a total substitute. We don't want people just to go to telehealth. It has to be a balance. I can't answer the question about the fracture liaison service, Annie. I think there are some details that are not in the budget, and sometimes the budget has to come out. Sometimes some of these things will get answered with time and need specific cases to be argued. Kate's question, I think, is a good one. We've seen that we've got a big budget, and then we may see big budget cuts from governments in about 2 years' time. Well, I think depending on which government is in power, depending on who's in power, depending on the state of things, I think that we always have to argue for health to get expenditure. We argue that health is an investment, not just a spending item, that it is an investment in the community, that it needs to be given. It will be hard to go back from some of the expenditure that has happened in health. The government has a commitment to medicines. It has a commitment to many other issues, and so yes, we always have to keep fighting for more, but we also don't want just more. We want how it's spent and where it's spent. Some of the measures in the primary healthcare plan and in the prevention strategy are not necessarily, and in all policy, is not necessarily more money, it's how it's spent. Some of the commentary about this budget has been it's a huge amount of money, but has it been spent in the areas that give us, if you like, as a community, the best bang for the buck? And I think that's something that time will tell, and we'll see things move around. Rebecca's asking me a question about opportunity for CHF and consumers to advocate for aged care services and the aged care package response. And I think the whole issue there, Rebecca, one of the things that's come out through COVID is the relationship between aged care and healthcare. And I think it's an important point to remember, which is that aged care services are supposed to provide aged care, but the people, the older people actually are full citizens and they have their Medicare card and they should be getting their health services as the rest of us do, through Medicare, through public health systems, through public hospitals, through accessing GPs, specialists, etc. And so what we probably need to do is to make it clearer what the aged care package is, what the health stuff, and make sure they're integrated and make sure there is more in-reach into residential aged care for people who need it, and people living in the community still have full access to aged care and get the services they need, that the health system doesn't think, oh, they've got an aged care package, it'll take care of it, because that's not what it's funded to do. And we see that all the time, particularly specialist palliative care, access to mental health services for people on home care packages has become had been quite problematic, where you were excluded from a better access package if you're in residential aged care, even though you have might have high mental health needs. And COTA, as one of CHF's members and CHF, had been arguing to have that reversed and to recognise that people are citizens if they're in aged care. Don't think we have any more questions. And yes, people are commenting in the chat box, which I thought we'd closed off, but obviously we didn't. That's okay. Always got to check the chat. I mean, yes, there are some people who don't get telehealth, and Penelope has made the point, that some people are not getting it. You can't get telehealth in residential aged care. And that's an issue, and we really don't know. We would say that you need to have it. I mean, one of the issues about residential aged care, which COVID has highlighted, is the lack of good primary health care going in, and the lack of coordination between them. And telehealth would seem to solve some of the problems. Again, Penelope, you're asking about a return to universal access to telehealth. I don't think we will see certainly the current thinking is that it won't be universal, that it will always be tied to, in some way, you're having an ongoing relationship with a healthcare provider. And I think there are some groups within the community where that is problematic, and I think that's going to be one of these areas of policy where we're going to have exceptions, and I think that's going to be one of the ways that we need to try and deal with this. And maybe it is that, and some of it may be that if you don't have a home visiting doctor, then you're going to have to come up with another solution. So I think the general principle will be have a relationship, and then we'll have a set of exemptions, I think is what we'll probably end up having. The budget didn't address the issue of consumer involvement and paying consumers for their work. And one of the things we found through COVID and our CHF's Consumer Commission on health reform has highlighted the fact that during COVID, consumers tended to get shut out of the discussion, that consumer engagement for many jurisdictions, not all, but in many jurisdictions and on many areas, the first thing to go by the wayside was consumer engagement, and everybody just dealt with the crisis. and we need to argue that this isn't appropriate, and we will do so, and that we want to have a stronger voice for consumers in the future. We have always put that as part of our budget submissions, and I know that the Consumer Commission is going to make some recommendations on that about funding for proper consumer engagement, funding for not just for people, not just for people to be there, but funding for consumers to participate is a key area of health, and we need to get it right, and it's been ignored, and we need to keep arguing, but that's for further down the track, I think, and as part of the reform agenda that we'll be prosecuting. In terms of digital health, apart from telehealth, there wasn't anything really. We know there's e-prescribing, which is coming down the path. We know there's a revisiting of the National Digital Health Strategy. There's currently a review of My Health Record, and we know that there was a plan to put it on a new platform. There wasn't really a digital health / virtual care agenda. It was just seen as telehealth, and I think this is where this budget, although it was enormous in money, was very narrow in what it actually provided initiatives in. It was just a few things where the money was going, and some odd bits and pieces on the side, but there wasn't any big reform agenda. And so I think it goes back to that. And clearly we need more of a digital health revolution, and telehealth is just a subset of that. There's a question about people on the DSP supplement and people with disabilities being ignored through the COVID epidemic and not being included in funding. And I think this is definitely an issue. And it's not an area that CHF has done a lot of advocacy in, but I think the issue about people on disability support pension getting adequate access to healthcare is an issue. I think them getting the additional payments, the supplements, and whether they get the $250 $250 supplements, I think is also an issue. And I think ACOS and others who are concentrating on income support advocacy are trying to push for it to be sort of a universal, that we shouldn't be picking winners about who gets adequate income support, that everybody should get it. And people on disability probably need more support because they have extra costs involved in just living their lives, and they were not front and center of on COVID, and that's true. And I think we'll just have to, as a community, we're going to have to keep advocating for that, but it's not something CHF has done a lot of work on. Somebody's put a comment, I think it is, about the delivery of medicines during COVID and the cost of the service. There is a commitment to continue the funding for pharmacy to provide home delivery of medicines for people who come into the category of being vulnerable. That was extended under the measures around telehealth that were announced prior to the budget and are included in the budget. So it should continue for at least until March next year, and then people will have to pay for delivery. But at the moment, if you're in a vulnerable group, you shouldn't be paying for the delivery of your medicines if you can't go to the pharmacist for whatever reason to collect them. And that was a key successful COVID measure to just reduce the spread of COVID, to stop people having to go into a pharmacy. So we have got to the end of the questions, and thank you all for those. If there are any other issues that come up that you think of, you can contact us on info@chf.org.au and we can get back to you. I don't know whether you want to add anything else, Leanne?
Good.
Yep.
Wrap it up.
You.
Yes. Oh, no, you do it.
Oh, okay. We're having a bit of indecision here. So thanks for your time, everybody. We hope that this has been helpful. We would be interested in any feedback. We will try to get back to some questions. The next few things for CHF is we have our Consumer Commission will be reporting by the end of the year. And we'll be hoping that we'll be able to do a webinar to discuss the results of that work that some of you have been involved in. We also have, for those of you who are members of CHF, we have our Members Policy Forum on the 23rd of November, and we also have our AGM on the 23rd of November. And obviously members are welcome to attend both of those events. And so we'll keep advocating for the things that we want. We'll be writing a budget submission for the budget 2021, which seems to be so much closer than one would have hoped. And if you have any ideas about issues that you want CHF to take forward in budget 2021, if you can send them to us, that would be very happy to hear from you. Some of them you've heard that we've already flagged in this presentation we will be taking forward. So there's nothing else for anybody to question. We might leave it there. Thank you all very much.